Ritika, are we good to go?
Sir, we can start in 10 seconds. Yeah,
Okay.
10 seconds. We are live, 10 seconds. Yeah.
Can we begin?
Yes, ma'am. Yes, ma'am.
Okay.
Hello, everyone. So we are here today to discuss a very, very important topic, that is gestational diabetes. So this program has been organized by the Endocrine Society of India Diabetes in Pregnancy Task Force. And gestational diabetes is a very, very common condition. So it's there in like 1 in 5 pregnancies. And to some extent, this is also preventable. And the first step to prevention is to know about the disease, is to become aware about what are the steps by which we can prevent it, and also at the same time, what we should be doing during pregnancy so that the safety of the mother as well as the baby can be ensured. So pregnancy can be taken as an opportunity towards a positive step towards better health, and we should not be alarmed about pregnancy and diabetes and usse kya hoga, usme kya problem hoga. So this is an opportunity to be healthier, and not only for ourselves but also for the future generation. So with that note, I have the pleasure of inviting Dr. Gagan Priya, who is the coordinator of the Pregnancy in Diabetes Task Force, along with me. And she will teach us, along with some very, very eminent endocrine faculties from all over the country, about how we can prevent diabetes in pregnancy or gestational diabetes. So over to Dr. Gagan for taking this forward.
Thank you so much, Dr. Saptrishi Bhattacharya. So I think Endocrine Society of India has taken this initiative that we should discuss diabetes in pregnancy up in front, because it is an important problem not just for the mother and during pregnancy. It has long-term implications for maternal health. The mother is later at risk of diabetes, and also for the health of the offspring. Children born to mothers with GDM, they also are at risk for future problems, which are not, we're not discussing this to alarm you, but as to inform us how we can actually reduce this risk. And for this, we have an excellent panel of endocrinologists, eminent endocrinologists from India, who will be discussing this topic with us. And to lead the team, of course, is none other than Dr. Sanjay Kalra sir, who is a past president of Endocrine Society of India. Currently, he is the treasurer of International Society of Endocrinology and also the Vice President of South Asian Obesity Forum. He works in Bharti Hospital, Karnal, and he has been a mentor to almost each one of us. And along with him, we have Dr. Lakshmi Nalini Kopale. She is a very dynamic and brilliant endocrinologist who has just published a textbook in geriatric endocrinology last month. Dr. Lakshmi works at Fernandez Hospital in Hyderabad. And the third cog in our wheel is Dr. Shubhankar Chatterjee, who is a young dynamic endocrinologist from Calcutta. He is been selected as the future leader of endocrinology by an international journal publication of significant repute in this time. So Dr. Shubhankar is currently working at Medical College, Calcutta. A warm welcome to all of you, and I'll just set the ball rolling with Dr. Kalra sir. So what exactly is gestational diabetes? We've been talking about it, but how does it differ from other forms of diabetes, and what exactly is it?
Thank you so much, Dr. Gagan, and good evening to everyone who is logged in with us. In general, when we speak of diabetes, we speak of two types, type 1 and type 2. But GDM, gestational diabetes, is different from these. G for gestation, so that means we diagnose it during gestation, during pregnancy. The lady comes up with high glucose levels, and she's quite sure that she did not have detected diabetes prior to conception, prior to becoming pregnant. So G is for gestational. DM is diabetes mellitus. So it is diabetes mellitus, and it's characterized by high glucose levels. You can check these levels in a fasting state, in postprandial state. You can check them after a glucose tolerance test. And some people suggest an HbA1c as well to diagnose GDM. How does it differ? When we speak of type 1 and type 2 diabetes, usually we think in binary terms. We think that either the person has insulin resistance or the person has insulin deficiency. Insulin resistance for type 2, insulin deficiency for type 1. But we now understand that these are not two opposing factors. It's not like, it's not like linear physics or like Western philosophy where you have a binary dualism, one thing opposing the other. It's not like that in endocrinology or diabetes. It's more holistic, more like quantum physics, like Einstein's physics. So apart from these two factors, what we have in GDM is gestation. And gestation is characterized by one more endocrine gland, that is the placenta. The placenta gives nutrition to the fetus, to the baby, but it also produces hormones. It is a temporary endocrine organ. It produces steroid hormones as well as peptide hormones. Now, some of these peptide hormones cause insulin resistance. One example would be HPL, human placental lactogen. The role of HPL is to create more energy, create more nutrition so that the mother can produce milk for the baby. There are also hormones from the placenta like human placental growth hormone. And many of the hormones that we tend to equate with the hypothalamus, they are also secreted by the placenta. Other hormones that we think come from the adipose tissue, they also come from the placenta during pregnancy. All these work like insulin resistors, and they increase the demand for nutrition. The body responds by increasing glucose levels. Up till a particular level, this is adaptive. So the mother is increasing her glucose levels to take care of herself and the unborn baby. But when this goes overboard, this becomes maladaptive. And that is what causes gestational diabetes. So let's put it together. Gestational diabetes is diabetes that is diagnosed during pregnancy. It can occur because of insulin resistance, but specifically it is due to insulin resistance caused by peptide hormones that are being secreted by the placenta. The moment pregnancy is over, once we have a healthy baby, gestational diabetes should disappear ideally, and many times it does. But it does leave a lasting scar, and it can always come back as permanent type 2 diabetes. And that is why we need to be more careful.
Right. So thanks. That was quite lucid. Dr. Nalini, so why should we worry about gestational diabetes? Like, what are its implications?
A very important question, Dr. Gagan, and good evening, everyone. Blood glucose levels in that pregnant woman, when they go up beyond a certain level, they can impact the baby. And not just the baby, they can impact the mother also. And then this effect is not just the short term. It can be a long-term effect also. So how does it affect the baby? When the glucose levels are very high, they go from mother to the child. So this high fuel level in the baby can cause a high birth weight or big baby. So this big baby, when the size of the baby is big, the chances of normal delivery come down. The risk of birth injuries become higher because the big baby is now passing through a normal canal. So we are seeing a higher percentage of injuries that can happen if this big baby is delivered to normal delivery methods. And let us assume that everything went on well and delivery and everything was normal, non-significant. But when the baby is delivered in the early newborn phase, especially in the first 1 to 2 days, the baby of this mother who has had uncontrolled blood glucose levels can have reactively very low blood glucose levels. We technically call it neonatal hypoglycemia. So it is important to control blood glucose levels of the mother, not just 1 or 2 months, but till the time the baby is delivered to prevent this low blood glucose level in the baby. So when we're talking about these two events, okay, there is something else we need to understand because it's not just big baby that can happen, but when this blood glucose travels from mother to the baby, in between the placenta intervenes, and this passage of excess glucose can lead to abnormalities in the placenta, which can cause preterm deliveries. Because lungs are formed, but their maturity and ability to hold oxygen develops only later, what happens? This baby who's born preterm, that is before the time happens, before the term happens, this baby's lungs cannot hold oxygen. We call it respiratory distress. And this is one of the most dreaded complications in the newborn period. To avoid all these things, good control of blood glucose levels is very essential. So these are the short-term complications. What can be the long-term complications? This baby born to a mother with uncontrolled blood glucose levels is at a very high risk of obesity and also type 2 diabetes mellitus. Now imagine this is a girl child who is at a risk of type 2 diabetes, and this risk started even before the baby is born. Now this baby is going up into a adult female and bearing children, and this woman now is again at a risk of diabetes. So we are transferring diabetes across generations, which could have been avoided if we control blood sugar levels. So this is all about the baby, short term and long term. Is there any implication on the mother? Yes, there is a long lasting implication of the mother also, because when the blood glucose level is higher, and we have discussed that placenta can get affected, there is a chance of blood pressure increasing. This together further increases the risk to the baby, and then along with blood pressure, this gestational diabetes is increasing the maternal risk of permanently getting diabetes. The risk is to the tune of 50 to 60% in lifespan. That means a lot of women might end up becoming diabetic if they don't take care. So that risk, coupled with increased risk of gestational diabetes in future pregnancies, we need to be very careful about this entity. So yes, there is every reason for us to worry about. Why? Because the safety of the delivery is jeopardized, because immediate health of the newborn is affected, and long-term health of both mother and child can be affected. So we need to be concerned and we need to be taken care of. And this is in a good fashion and not to panic. Why? Because when we know what is at risk, we can take care, we can avoid, and we can be safe.
I think this is something what you highlighted is what Dr. Kalra often mentions as transgenerational karma. So it's like, if we improve the generation, the health of this generation, we actually will earn good karma down the line also, and maybe make a better society, a healthier society. Dr.
Absolutely.
Shubhankar, yeah, Dr. Shubhankar, which women are at risk of developing GDM? We've understood how it develops, but are there any factors we can consider that maybe this lady has a higher risk?
Thank you, sir and ma'am, for including me along with this eminent endocrinologist all over the India. So we have to understand the risk factors of GDM to uh, correctly screen those mothers, but and also to see those modifiable risk factors which can be treated or taken care of before the actual pregnancy happens. Now, first coming to the modifiable risk factors of GDM. So, being overweight or obese, particularly if the BMI is more than 25 kg per meter square, statistically saying with each uh, unit of increase of BMI, the risk of having GDM increases by 9%. And also the other diseases related to insulin resistant like polycystic ovarian syndrome or metabolic syndrome, they are also at risk of developing GDM. And also, as you know, the other alleles like unhealthy dietary factors before pregnancy, being a sedentary uh, lifestyle, and also there are certain psychosocial factors as well. Now coming to the non-modifiable risk factors, they may not be treatable, but to know them it's extremely important to properly screen those ladies before pregnancy. So like maternal age, some says it is more than, if it is more than 30, or some says if it is more than 35, they are at risk of developing GDM. History of twin pregnancy, ethnicity, particularly non-white ethnicity like South Asian, Hispanic, African, that is we are all Indians are actually having non-modifiable risk factor like ethnicity to develop GDM. And also family history of diabetes, previous history of GDM, previous history of polyhydramnios, previous history of delivering large for gestational age baby, particularly if the birth weight is more than 4 kg, and also previous unexplained prenatal loss or birth of a malformed infant. They are actually the risk factors of developing future GDM. While I'm saying this in simple terms, this history should be taken by any physician, any gynecologist, any primary care physician, and also uh, uh, general public should also know about these facts when they are planning a future pregnancy.
Yeah, I think rightly highlighted. And anybody who's had a prior GDM, those women should definitely consult prior to planning their next pregnancy. Dr. Kalra, we've often heard these figures that, women in all over the world, if you look at IDF Atlas, 1 in 6 women may develop gestational diabetes. But when it comes to the Indian data, there's data that 1 in 4 women may have GDM. So why is that? I mean, what is different about the Indians that we are at a greater risk?
We are more predisposed to virtually every metabolic disease. And sometimes I am reminded of this adage that, first of all, God, the creator, he looks at, they look at the strength of your shoulders and then they decide to burden it. So perhaps our shoulders are stronger. Considering GDM, let's look at the biomedical as well as the psychosocial aspects. We look at the biomedical aspects pre-pregnancy, then during pregnancy, and we look at the psychosocial aspects both pre and during pregnancy. So if you look at it preconception, first of all, we are smaller size. Our bodies are less well built, which means that if we are smaller, if Indian women are smaller and lighter, they will have lesser pancreatic mass, they will have lesser beta cell mass, and that will mean relatively less insulin deficiency. Do note that the total beta cell mass in a lean adult is only 0.8 grams, and in an obese person, just 1.2 grams. So even a 0.01 gram or 0.1 gram reduction in beta cell mass will be highly significant. The second thing is that because we are lesser built, we have lesser muscle mass as well. And the muscle is a very strong organ or player when it comes to insulin sensitivity. So it is possible that our women have less insulin sensitivity. This is preconception. If you look at preconception psychosocial aspects, increase carbohydrate load because our food is so tasty. What can we do? And my favorite food, Dr. Gagan Priya, is pesarattu from Andhra Pradesh, along with the gunpowder uh, dry pickle. And that is awesome. So our carbohydrates are tasty, so we end up eating more. And that might not have been such of a problem if we had exercised properly, but because of multiple factors, socio-cultural as well as psychological, we exercise less. So again, we end up with more of insulin resistance. To add to this is domestic stress, which increases cortisol. And many Indian women, this is an unspoken epidemic. They face very quietly, they face a lot of domestic stress, overt as well as covert, which increases insulin resistance. Now, let's come to within pregnancy, what happens. Within pregnancy, we already spoke that the placenta is a major player when it comes to, modulating metabolic health. So the Indian placenta is much smaller than Western placentas. Our surface area is roughly 450 grams. On the other hand, when you look at placentas from the West or even from the Middle East, the average weight is 675 grams. So the smaller placenta has to work harder to ensure nutrition for the baby. And actually, it works harder because if you look at the birth weight to placental weight ratio, birth weight to our children are lesser in size when they are born, but our birth weight to placental weight ratio is 5.75 is to 1 in India. On the other hand, for Norway, for Qatar, it is 5 is to 1. So which means that our placentas are working 15% extra, 20% extra with more efficiency to ensure nutrition for the fetus. They work harder, so they tire out as well. And placental aging occurs earlier in women. That is why you will find most Indian obstetricians saying that we cannot follow the Western guidelines. We cannot go up till 39 weeks or 40 weeks term pregnancy. We have to deliver earlier. Placental aging occurs in the form of a vascular deficit and also abnormal pilus morphology. One specific thing I would like to talk about when it comes to physiology, and that is cortisol. Now, in the normal non-pregnant adult human being, cortisol secretion is mediated by a negative feedback mechanism. So there is a hypothalamus that secretes a hormone called CRH that works on the pituitary gland that secretes ACTH that works on the adrenal that secretes cortisol. If for whatever reason you have too much of cortisol, the hypothalamus and pituitary will step back. They will say, okay, you already have so much of stress. Let me step back. Let me reduce my CRH secretion. So usually we remain in that bandwidth of physiology. The opposite happens in pregnancy. Placenta secretes CRH. We already mentioned that it secretes many hormones that are traditionally linked with the brain. And when you have more of cortisol in a pregnant adult woman, that cortisol goes to the placenta. It gives a message that I'm in stress. And the placenta secretes more CRH. So it becomes a positive feedback mechanism and a vicious cycle. More CRH from the placenta, which means more stimulation of the adrenal gland, more cortisol. And you end up with a self-defeating kind of a stress cycle. So these are some of the reasons why Indian women are more prone to GDM.
So I think if I summarize for the general, lay people, the Indian women are at risk because of lower size, less muscle mass, and also because of our dietary patterns. But eventually, we have to understand that diabetes is a hormonal disease. And there are a lot of hormonal changes that happen during pregnancy, which tend to go haywire in, pregnancy with diabetes, particularly in the Indian women who are predisposed. So I think that puts endocrinology at the forefront of, management of GDM, I guess.
And also, Dr. Gagan, it has to be a comprehensive approach. It is not that just I give you the best insulin or I give you the best metformin, and then we forget about everything else. You have to look at the lady's family, her psychological health, her social health, and the entire family, the entire society has to be involved in improving maternal as well as fetal health.
So with that, Dr. Nalini, can we prevent gestational diabetes and how can we do that? We've talked about a lot of big things, scaring people, but let's talk about the positives.
That's a very, very vital and important question. When the basis of it comes in understanding that many diseases, especially when lifestyle component is involved, that is our diet and exercise, the risk of these diseases can be decreased. But just like any other disease, we can never predict. We cannot play God. So we can decrease the risk of it. But to understand that, we need to understand the root cause of what is happening here. As Dr. Kalra just now pointed out, there are a lot of hormones that are produced by the placenta which increase the blood glucose level. And this increased blood glucose level in normal women who do not have GDM is matched by the increased insulin production. Insulin is the hormone which controls blood glucose level. So in these women who are getting gestational diabetes, it is observed that the insulin produced is not adequate to control the glucose producing hormones with the placenta. So glucose is increasing, insulin is not able to increase. There's an imbalance. Because of the imbalance that has caused, there is gestational diabetes. So what are these factors? Like Dr. Chatterjee was telling us, what was he telling? Modifiable risk factors, non-modifiable risk factors. So what are these? Factors which we can change and factors which we cannot change. Factors which we are born with. Whatever we are born with, that is, we are Indians. We cannot change that. We are born in probably to parents who have diabetes. We cannot change that.
We can change the passport, but we can't change ourselves.
Yeah.
Very, very rightly commented, sir. So factors which cannot change, they are there with us. Everybody, every one of us, all the women here face that. So there are definitely factors which we can change. What we eat can change. How we eat, we can change. And how we exercise, we change. And how we look at diabetes can also change. And more importantly, it's very essential to maintain a healthy lifestyle, especially in women between 18 to 45 years of the age. This age is called the reproductive age group. So in this age group, a woman can get pregnant anytime. So planned pregnancies and maintaining health and proper weight before conceiving is very important. So many of the pregnancies in India, almost 50 to 70% of the pregnancies in India are unplanned pregnancies. So what do? We generally maintain health. It's not wrong to eat correctly. It's not wrong to follow a correct lifestyle. So let us follow a correct lifestyle wherein we ensure that we do not go into the bracket of being overweight, being fat, that is being obese and all that. And let us maintain a good health with diet, exercise, our lifestyle and good sleep. These are the things which we can change. So in short, we can say that gestational diabetes is where our genetics, that is what happens to us, meets the environment, that is what we do to our cells. So when we take care of ourselves, we can beat the things which cause our genetical disability or gestational diabetes in this case.
So a healthy lifestyle before planning a pregnancy and then during the pregnancy, I think is something that is something in our hands. So we can definitely achieve that. Dr. Shankar, a common, idea among the general people is that during pregnancy, a woman should eat for two. And the average weight gain should be 15 kilos. If you've not gained that much, you're not eating well. And there's this whole, in Punjab side, we have this panjiri and laddus going on in surplus. So of course, cultural differences across India do exist. But what should be, should they really be eating for two? And is this weight gain recommendation for all women?
Yeah. Ma'am, first thing first, that the eat for two concept is a myth. Nutritional needs do increase during pregnancy, but calorie requirements rise only modestly by about 300 to 400 kilocalorie per day, and that too in the second and third trimester. Now, excess calorie intake will ultimately end up in excessive gestational weight gain, and that is the main risk factor for developing GDM. Now, the second thing that it is true that ICMR in its guidelines state that an average weight gain of 10 to 12 kg in addition of 300 to 400 kilocalorie per day above that adult reference range is recommended during second and third trimester. But the thing is that this is not the case for every woman. Actually, Institute of Medicine, what they suggest that we should group our pregnant lady according to their BMI, and accordingly we have to say them or counsel them about their optimal weight gain, allowed weight gain during pregnancy. And this is not 10 to 12 kg for all. Like if the mother is underweight, we can recommend recommended range of weight gain is 13 to 18 kg. If she is normal weight pre-pregnancy, then the range goes up to 11 to 16 kg. But when it comes to the overweight, then it is only 7 to 15 kg. Having grade 1 obesity, only 5 to 9 kg. And most importantly, for grade 2 or grade 3 obesity, less than 5 kg weight gain is recommended. So this is actually that the data 10 to 12 kg is not a fixed thing and should be modulated or recommended according to the baseline pre-pregnancy weight of the mother. So the focus should be on the quality of the food, nutrient dense meal rich in protein, fibers, fruits and vegetables, and not the quantity, or not just the calorie intake or binge eating or having easily available sugary carbohydrates.
Yeah, so I think what you've highlighted is very important, and I'd like to re-emphasize that weight gain in pregnancy should happen in the second half of pregnancy. Too much weight gain or too rapid weight gain in early pregnancy actually will increase the risk of developing a GDM down in the second half. So we should focus on a pre-pregnancy weight approach. So if the weight is in the category of overweight or obesity, frank obesity, then we should, limit our targets. And most of the weight gain that happens for fetal growth is actually in the second half. Moving on to, a scenario, Dr. Kalra, that there is a woman who's planning a pregnancy. Let's say she is already having a body mass index of 30. She's having obesity. And she also has a strong family history of diabetes. What checklist of, let's say, should she have a preconception counseling? That's question number one. That should she consult a doctor before planning this pregnancy, and who should she consult, and what would you recommend? What tests would you recommend?
This is really, really, really important. And no matter how much we talk about it, still we need to speak about it more. First of all, like Dr. Nalini also mentioned, many of the pregnancies in our country are unplanned. But ideally, you should have a planned pregnancy. So go for a preconception checkup. Do go to an obstetrician who is finally going to take care of you. But if you have any metabolic disease, if you're at high risk of GDM, then it would be worthwhile consulting an endocrinologist as well. What are the high-risk factors where you would want to consult an endocrinologist? Let's look at it from an AEIOU perspective. This is how I find it easy to remember. A is for antecedent history. Have you had a history of metabolic mishap in the past? Have you had a history of pregnancy mishap in the past? Maybe gestational diabetes, maybe preeclampsia, perhaps loss of a fetus. So any antecedent history. E is for elder. If you're on the older side, maybe a primary gravida more than 35, or uh, uh, planning pregnancy and more than 40, then you must consult an endocrinologist. E is for also informed and in-house. Informed would mean educated. The higher the education level, the more the chances of gestational diabetes. In-house means that if you've had a family history, perhaps you yourself did not have any antecedent history, but you have a family history, your mother, your sister, cousin sisters have had GDM, then do consult an endocrinologist. So we've done AEI, antecedent history, elder, informed, and in-house. O is for overweight. If you're overweight or obese, then first of all, manage your weight, then plan pregnancy, and the outcomes will be better. You may feel that your endocrinologist is asking you to postpone pregnancy by a few months. The speed is going down, but actually the velocity will improve. Velocity means that speed in a particular direction. The direction that we want is a healthy mother and a healthy baby. U is for urban. If you're an urban dweller, again, you must visit an endocrinologist. With this AEIOU, if we abide by it, and if we abide, then we will always be on target. Abide, this is how I remember actually, from both an obstetric and a metabolic perspective. A is for anemia. Make sure that your hemoglobin is normal. And if you're from a high-risk group, perhaps Dr. Gagan and Dr. Subhankar will be best placed to speak about this. If you're from a high-risk group where you have hemoglobinopathies, then preconception counseling is very, very important. A for anemia and hemoglobin type. B is for blood pressure. Check your BP. Do be aware that the definitions of high blood pressure for pregnant adults and non-pregnant adults are different. So trust your obstetrician when she says that your BP is high and I need to give you medicine or I need to put you under extra surveillance. I is for infection. And especially if you've had any antecedent history, then infections like rubella, mumps, CMV, these should be checked for before planning pregnancy. D is for diabetes or dysglycemia. That is what we are speaking about. And I'm sure the Endocrine Society of India in future events will take us through how to screen for diabetes. But if you're in preconception, then you will screen the same way that other non-pregnant adults are screened for. You can do a fasting, you can do a GTT, glucose tolerance test, you can do an HbA1c. Do note that postprandial glucose is not a screening test. It is a monitoring test. E is for endocrine. And in endocrine, we have things like thyroid, pituitary, adrenal. TSH is something that should be advised for all women planning pregnancy because the risk of autoimmune thyroid disease is upwards of 20% in Indian women. When we are on endocrine, we should not think only about thyroid. Think about obesity management. We mentioned that. And when you are thinking of obesity, do think of nutrition and exercise. Get into the right habit in the preconception phase. It would not be a good idea to say that now I'm in first trimester, now let me start going to the gym or let me start running marathons. That you should do before. If you've got into the hang of it, if your body has got used to it, then you can continue during pregnancy, but do all that in the preconception. So ma'am, if you allow me to repeat, AEIOU was antecedent history, elder women, informed and in-house history, overweight or obese, and urban residents, do consult an endocrinologist. For everyone else, do consult an endocrinologist and or an obstetrician where you have to check for your anemia and hemoglobin status, blood pressure, infection, diabetes, and endocrine factors. So that is ABIDE. Just abide by this advice and we'll have a successful and happy pregnancy.
Sure, sure. So Lakshmi, Nalini, coming to you now. So when we talk of healthy diet, there's no clear definition. And also this question about for women is like, can I exercise during pregnancy? What kind of diet I should follow? So if you were to counsel a woman in your clinic, let's say in just 2 to 3 minutes, what would be that counseling?
For this particular woman, I would say who's already starting with obesity and then who's presenting with gestational diabetes, it's very important to understand that what we put into our mouth will give us the result. will give us the result on the glucometer as well as the output of the pregnancy, the fetal outcome. So we need to be careful what we eat. So identifying that, changing eating patterns and changing the way we were eating is very important, because it's very crucial. In the clinics also, we see that there's a lot of inertia in changing the type of eating pattern. Rice eaters are majorly present in Hyderabad and southern part of India, and it becomes very difficult because it's polished white rice. So eating patterns need to change, as Dr. Chatterjee was telling earlier, that complex carbohydrates are important. High protein diet is important. During pregnancy, it's very, very important to adhere to correct diet, because diet is the load that we are giving our body, an essential load. How we give it is very important. Always the dietary advice should be of a nutritionist who is specialized in pregnancy specific nutrition. This is a recommendation throughout the world as well. And when we talk in the OPDs, we tell them complex carbohydrates, avoid simple carbohydrates and sweets, take good amount of vegetables, and portion control for fruits, because fruits have naturally natural sugars which are also not so good for the baby when taken excessively. Next is protein. Protein is very important. Good quality protein from egg, milk should be taken, and then fats percentage should be cut down, especially because this woman is already obese, overweight category mother. So we need to be careful with that. So this is the main part of the diet that we talk about, the major carbohydrates, proteins and fats and micronutrients. And the woman needs to take in the supplemental nutrition factors also, should not miss her iron as well as calcium, as well as folic acid, especially in the first trimester, folic acid should not be missed. So this answers the first part. The dangerous, scary second part is the exercise. Often the moment a woman conceives, entire family says, you just lie down, you don't move. That is the kind of myth that is percolating throughout all the society, to all the stratas of the society. So how do we counter this? We first understand whether there's any problem with the pregnancy which prevents the mother from exercising. If there is no problem in the pregnancy, a minimal of 15 to 20 minutes activity after every meal ideally controls blood sugar levels postprandially, the glucose which is coming out of the food. That glucose needs to be controlled. How do we control it? We move the muscle. An active muscle without the need of insulin hormone, which was less as we discussed earlier. So this glucose is utilized very well when the muscle is moving. So 15 to 20 minutes walk is very simple exercise. Other than walking, usually swimming, cycling are also considered safe, but many people in our country are averse to doing these. So walking always suffices. And any other exercises which improve flexibility and certain yoga exercises guided by the physiotherapist would be an excellent way of keeping the body's metabolism going.
So I think the answer is yes, exercise can be done. It has to be individualized. And nutrition, we follow the basic principles. I think you've already touched upon supplements also. So Dr. Shubhankar, my question to you will be, let's say this woman has pre-diabetes before pregnancy. So we've already put her on lifestyle changes. And there is this drug metformin, which we use commonly in even in pre-diabetes stage in many people. Would it be a useful drug? Let's say somebody has put this woman on metformin and she has this question, can I continue it during pregnancy? Should I take it during pregnancy? So what would your answer be?
Yeah, ma'am. In women with pre-diabetes or other thing like having PCO or obesity or history of GDM, metformin actually can be considered preconceptionally to improve insulin sensitivity and also to improve the ovulatory function. So, however, it should be ideally the decision taken care of case by case basis and should be pre-prescription counseling about metformin is probably also needed. That there are multiple controversies and trial result or SRMA result. There are differences, but in summary, what we can actually tell the patients that, or tell our obstetric friend that the metformin giving metformin is actually associated with lesser incidence of macrosomia or birth weight, lesser incidence of cesarean section, lesser neonatal hypoglycemia risk or NICU admission, and even lesser maternal hypoglycemia if the patient is on insulin. Actually, it stabilizes the insulin dose. However, the risk of SGA child or a trend towards developing preterm delivery is increased. Now, while counseling the patient, we can actually uh, saying these things that metformin is actually safe in terms of immediate maternal and fetal outcome, having excellent safety and efficacy in overweight and obese pregnancies. And metformin and insulin are actually friends, not competitors. Have long-term mother and child safety data is available for metformin. So these things, however, there are concerns like if the patient is actually lean or underweight, avoid using metformin, and possibility of childhood obesity, especially those who were SGA or and shows catch-up growth in long-term study, but not in all studies. And also that although metformin crosses the placenta, unlike insulin, it has been shown in systematic review having longer term trial data that metformin is actually safe in pregnancy and also uh, in terms of the risk of those children uh, in developing obesity in future. So my take would be yes, yes for metformin. However, it should be prescribed case by case basis and probably best avoided if the patient is lean. And also, as Dr. Lakshmi Madam said, that that recommended supplements that folic acid should be given, vitamin D and vitamin B12 is can be advised, particularly if deficient. And also, there are a role of myoinositol in although not very hard evidence is there, but there are studies regarding the efficacy and safety of myoinositol in pregnancy are actually to prevent GDM.
So I think what I gather from you is that definitely yes to supplements. Supplementation should be done adequately, including folic acid. And when it comes to metformin, it's a more nuanced decision that should be taken by a specialist because there are positives and negatives. But I think what data has shown that women who have overweight or obesity or just PCOS who don't have pre-diabetes, metformin actually did not reduce the risk of GDM. So let your specialist decide on that, maybe. I think that's the best answer. So we've had actually a very, very fruitful discussion. We've already been 40 minutes into this discussion. So I'll request our experts to give us, a one-line mantra for the women who are planning a pregnancy or any family where a woman is planning a pregnancy, starting with Dr. Kalra, sir.
5 simple M's to remember, Dr. Gagan and everyone who is listening. First of all, measurement. Don't shy away from measuring. Find out what's wrong and then you fix it. 4 M's to add to that. 3 are a must for everyone. Movement. Move your body, move your limbs, move your muscles. Meals and menu. Focus on your diet as well. And the third is mind style out of these 3. So the first was measurement for everyone, and then movement, meals and menu, and mind style. Keep them healthy. If required, we move on to the 5th M, which is medication. Again, do not shy away from that. The medication is meant to help you and your baby who is about to come. Just 5 simple M's to ensure happiness.
Yes.
I would say prioritize wellness and not just weight or numbers. Eat wisely, move daily.
Sure. Dr. Shubhankar, your...
Yeah. Yes, ma'am. I think, as Madam said, that unplanned pregnancy is the most frequent in India. So plan your pregnancy, stay active, eat smart, and know your numbers, as said. And prevention actually begins before the conception with healthy lifestyle. And achieving an ideal body weight is extremely important because we have to counsel the mother that you will actually eventually gain weight. So uh, achieving the ideal body weight before pregnancy is extremely important. Responsible motherhood in, or you can say that responsible parenthood is is important. That is responsibly sowing the seed after achieving a fertile soil, that is uterus, so that a healthy baby can be born with optimum maintenance of maternal health.
Yeah, so I think the message that comes across is that gestational diabetes can be prevented to a large extent by following a healthy lifestyle, preconception planning planned parenthood, and also by following healthy lifestyle during pregnancy. And even if gestational diabetes does happen, it is not a kind of a burden. It should be looked at rather as an opportunity that we can improve upon things, and we can improve the health of the mother as well as the child. So generations will benefit from such a positive attitude. So with that, on behalf of the Endocrine Society of India, I would really sincerely thank all the experts for this fruitful and very interactive discussion that we've had. And Dr. Saptrishi, any closing words from you?
No, I think it was a learning point for all of us. And the most important thing remains that so there are many things we know, but again, it becomes difficult to implement in practical life. So we just need to, along with knowledge, motivation is also important, and we all need to work together to do that. So we need, it's not only the challenge for the mother, it's the family which needs to work together on this.
So we'll thank all the viewers who have been listening on to us. We will have these sessions almost every month. We promise to come with more and more information on diabetes and pregnancy. We would love to answer your questions. So you can leave your queries on our ESI Facebook page or Insta page, and we will ensure that we answer your queries. Thank you so much to all the faculty for being here tonight. Dr. Kalra, Dr. Nalini, Dr. Shubhankar, and
Thank you, ma'am.
signing off on behalf of ESI from Dr. Saptrishi and me. Good night, everybody.
Good night.
Thank you.
everyone.
Thank
Good
you.
night, sir. Good night, ma'am.